Here's a question to ponder. Can people be predisposed to be prone to injury? Whether the answer is yes or no, injuries happen to everyone. More than 3.5 million sports-related injuries occur each year, and that number only includes children under the age of 14. You can imagine how many it would include if it was everyone. Could these injuries have been prevented? We don't know. But what we do know is that they can be repaired. And in many cases, this task is placed into the hands of a sports medicine or orthopedic surgeon. Hi everyone, my name is Lauren Hickman, and to give you a little bit of background info about me, I have played sports my entire life. I basically was an athlete from the moment I learned how to walk, and I've played every sport under the sun, but within the past couple of years I decided to focus solely on lacrosse. And next year I will be continuing my education at the University of California at Berkeley, and as well as my lacrosse career. And if the answer to the question I posed earlier is yes, that people can be predisposed to be prone to injury, then unfortunately I am one of those people. I've been injured a little more than I would care to admit. About 4 years ago, I tore my ACL and had to undergo surgery to repair it. And that is my journey to recovery is what inspired me to want to help others who have undergone, who have had devastating injuries such as ACL surgery or other injuries. The great Hall of Fame football coach Vince Lombardi famously stated, "We will chase perfection and we will chase it relentlessly, knowing all the while we can never attain it, but along the way we shall catch excellence." And this quote is extremely relevant to both athletes and surgeons. Athletes strive for perfection in their sport. Likewise, orthopedic surgeons pursue perfection in their craft to benefit their patients. Also, this quote applies to my ISM journey. I know that I cannot be perfect, but striving for perfection will open many opportunities and lead me to great places. So I'm going to open up with my interviews. My first interview was with Dr. Sean Haslam of Texas Orthopedic Partners, and he knows a lot about ACL reconstruction, and what I thought was really neat was he studied ACL reconstruction in rabbits during medical school. And something else I really liked about him was that he was very family oriented. He was very adamant about putting what you value ahead of your work and finding the balance between family life and work life, because he has 6 kids and he has to be able to manage all of it. And he strongly believes that there's a need for more women in the field, which is a breath of fresh air, I believe. And my second interview was with Dr. Christian Royer of Orthopedic Associates of Dallas. And unlike all the other surgeons that I interviewed, he is a foot and ankle orthopedic surgeon, so he doesn't focus on sports medicine. And he said that being a doctor is similar to being a businessman. When I asked him how he manages his time, he said it's just like how businessmen go on a trip sometimes and they can't be there for every soccer game that their kids have and other events, but it's very similar to that. And something that he said that stuck with me was the only constant is change. And you have to be able to adapt to the world around you, because if you don't, and if you just stay stagnant, the world's going to keep moving and you're going to get left behind. And he stressed making the best out of every moment. He said he had a really good time in medical school, which was actually kind of rare because a lot of people moan and groan about medical school, but he made sure to have fun and have a good time. My third interview is with Dr. Catherine Coiner of UT Southwestern, and she is one of the team doctors for the Dallas Stars. And something that I thought was really, really cool that she introduced me to was the Perry Initiative, which is a program for high school girls to come and get hands-on experience with fields that are mainly male-dominated. So they go for a full day and they get to drill through bones and look at other really cool engineering stuff, and she's trying to spread that throughout the Metroplex. And she actually played college basketball like Dr. Christian Royer did as well. And she equated medical school to college sports because you have to be able to manage your time. And she something that she said that she wished she did was had fun along her journey, because if you're not enjoying what you're doing, you're not following the right path. Fourth interview was with Dr. Bruce Douthit of Oasis Orthopedics, and he was actually the first sports medicine orthopedic surgeon in Frisco. He worked alongside Dr. Pink and knew him very well, and he was the team doctor for Frisco High School back when we were the Coons. And the advice he gave me was to not major in biology, because you can study really anything you want to and still go on to be in medical school, and don't get into debt. And he said that his job is extremely exhausting, but it's worth it because he loves being able to see the immediate results of the patients. And my fifth interview was with Dr. Daniel Cooper of the Carroll Clinic, and he actually did my surgery, so I know him very well, and I had my interview over the phone with him, and because he's very busy, and I knew him, so it was easier to do that. And he is the head team physician for the Dallas Cowboys, so he handles all of the injuries to the players, and so he did Sean Lee's surgery, and in the case of Des Bryant, he didn't perform the surgery, but he referred him on to someone else who did. And with the responsibility of being a team doctor comes challenges, but he said that it's worth it because he loves the gratitude that his patients have. And he stressed the importance of getting on a patient's level, because if you don't and you just speak medical terminology all the time, it's just going to go over their heads and you're not going to be able to relate to them. And I experienced this firsthand actually a couple weeks ago when I was in there in his office for some knee stuff, and he came over and started drawing out what my knee looks like and what the procedure would look like on the little paper thing on the table that I was sitting on. And I thought that was really cool because I understand now, so it's not just him coming in and speaking over my head. And a tragedy in his life helped him become a better doctor. He said that he's much more sympathetic and can relate to patients and, as I said earlier, get on their level. And something interesting about all of my interviews was that three of the five doctors were Division I college athletes, and being a college athlete is very, very difficult because you have to be able to manage your time. But I think that goes to show that anything is possible with hard work and determination. And my research assessments, my first one was the 13-point shoulder ultrasound exam with Dr. Don Buford, who's actually in the area. It was a video, and he was breaking down the best way to internally view the anatomy of the shoulder, and it viewed the 6 different tissue regions, and that ultrasound helps diagnose shoulder injuries. And my second assessment was orthopedic surgery residency, and the residency focuses on multiple subspecialties such as foot and ankle, sports medicine, pediatrics, and the first 6 months of your rotations are non-orthopedic, so you get to experience the full spectrum. And senior residents have more independence to get ready for having their own practice, and if they so choose. And this is when I started focusing more on specific injuries and why ACL injuries sideline so many athletes. What I thought was really interesting, and I didn't know this before, the ACL is the only ligament in the knee that cannot repair itself. The PCL, MCL, they can form blood clots to fuse back together, but the ACL cannot. And there's a doctor up in Boston named Dr. Murray who's been working on a procedure to produce a blood clot for natural reconstruction, and if it works, it will produce less arthritis and cartilage damage after surgery. And if you can see here, that's a normal ACL right there. It's thick and strong, but then this is a torn ACL. You can't even see the 2 ends of the ligament, and all the white stuff in there is fluid that prevents it from forming a blood clot. And the effect of this was actually a clinical study, I believe, and it was the effect of playing surface on the incidence of ACL injuries in NCAA football. And most ACL injuries occur in non-contact situations, so sharp cutting and twisting. And there's a higher rate of ACL injuries on artificial turf, especially third-generation artificial turf, which is what most high schools and colleges play on. And this poses the question of whether it is worth, whether the price of the cheap cost of the third-generation artificial turf is worth the cost of the injuries that are happening in college players. And this article focused on women's injuries, and women are at higher risk of undergoing orthopedic surgery than men, and they're 8 to 10 times more likely to tear their ACL. This is due to anatomical differences, menstrual cycle, other things. The hips are shifted, and there's a imbalance of strength in the quadriceps and hamstrings, and they're focusing on new training programs to decrease chances of injury in women by strengthening the hips, strengthening the extensors such as the hamstring. And the anterior, my sixth assessment focused on ACL injuries in the growing skeleton, and the difference between young patients and adult patients is that in their bones, young patients have open growth plates, and so they have to use different grafts because some grafts that they use in adults block the growth plates, and if the growth plates are blocked, it will decrease the growth and cause serious issues later on in life. And you can see the little cracks, right? It looks like cracks right there and right there. Those are the open growth plates. And my last assessment was the future of treating ACL tears, less invasive surgery. And as I talked about earlier, Dr. Murray in Boston is focusing on the new procedure to do a natural reconstruction, and approximately 400,000 injuries to the ACL occur each year, and that's crazy, and it needs to be, there's something going on that needs to be fixed. And Dr. Murray's design is a sponge scaffold, so what they do is they infuse the sponge with blood and place it in between the two torn halves of the ligament, and it fuses back together. And what's different about this than regular surgery is instead of doing prehab, and which is physical therapy prior to going into surgery, they want immediate surgery so that the two halves of the ligament are least damaged, so they can put them back together. So as you can tell, I'm pretty passionate about ACL injuries, and so for my original work, I wanted to dive deeper into the study of grafts to find the best way to repair a torn ligament. And these are the questions I asked myself. So what makes a quality graft? What is necessary for an ACL graft? What graft is best for ACL reconstruction? And is there a new or different graft that hasn't been used yet? And so this is just a little bit of ACL basics. It's an extremely crucial ligament. It connects the femur to the tibia, and it's responsible for 85% of the movement rotation in the knee, and it's with the PCL. It is the guide of the central rotation of the knee joint, and tears most commonly occur from non-contact, cutting, sharp movements, and it cannot repair itself, so you have to take a graft from other sources. And the choice of the graft is based mainly on the patient's specific condition. So autograft versus allograft. Autograft is harvested from a patient's own tissue. So the two most common autografts are patellar tendon and hamstring tendon. And then there's allografts, which is harvested from a cadaver. And cadaveric tissue, if you don't know, is tissue from someone who is deceased. And each has its own advantages and disadvantages that need to be considered by the doctor and the patient prior to surgery. It's important that the patient researches and know that their specific needs before they just jump into a specific graft choice. And so the patellar tendon is often referred to as the gold standard. With it has a 90 to 95% success rate, and the graft takes the middle third of the tendon, and along with two small bone blocks from the tibia and the patella, and this categorizes the tendon, the graft, as a bone tendon bone graft. As you can see in this little picture, that's the little bone plug, and then that's the tendon, and then that's the bone. And the bone tendon bone grafts are much easier to fix within the bone tunnels, and also the patellar tendon graft allows for possible reharvest if there's a re-tear. However, this is probably the most painful graft to harvest, and there's a long physical therapy because there is more atrophy in the quadricep, and the incision is much larger, and there's a serious incidence of anterior knee pain. That's probably one of the biggest issues. The hamstring tendon, as opposed to the bone tendon bone graft, is a soft tissue graft, and it doesn't have any bone blocks to fix into bone tunnels, but there are multiple variations of the approach to anchor the soft tissue into the bone, and there are new fixation techniques that exceed the pull-out strength of the patellar tendon. And advantages of the hamstring tendon are that it's a small incision, less painful to harvest, there's fewer problems with knee pain, less atrophy, and it's good for younger patients because it doesn't close the growth plates. However, the soft tissue graft has a slower healing rate, and there's a risk of tunnel widening, which is a condition in which the original borders of the bone tunnels in the femur and tibia expand out or enlarge, which can cause it to be a loose graft. And the hamstring does not grow back after the harvest, so there's an average of about 10% loss of the tendon after recovery. And this was a clinical study that I looked at that it was bone tendon bone versus hamstring, and it closely measured the statistical differences between bone tendon bone and the hamstring graft, and it tested stability, range of motion, and strength in 9 different studies for both grafts. And the results included total graft failure, side to side, differences in laxity, other examinations, loss of motion, and though the numbers fluctuated, there was no clinical significance between the two grafts. So there are advantages and disadvantages for both, and neither one is better. The allografts are mostly the patellar tendon, hamstring tendon, and Achilles tendon harvested from the cadaver. And advantages to this is there's no risk of pain or scarring because it's not harvested from the patient. It's a quicker surgery, there's less post-operative discomfort and less atrophy. However, it is not recommended for the first reconstruction, and there's a serious risk of infection because it cannot be 100% sterilized because it can kind of eat away at the graft. And there's an increased risk of re-injury due to less pain because after surgery, some patients think that they're ready to go back to sports, but they're really not healed all the way, and so they go back out there and tear it again. And they're also extremely expensive, and there are not many young, healthy donors that can provide grafts for young athletes. And synthetic grafts possess the most potential of improving ACL reconstruction. However, no synthetic grafts to date have met qualifications needed for a lasting ACL substitute. They've come and gone, but they're usually too rigid and end up fragmenting or wearing away after constant movement of the knee. And it must be strong with just the right stiffness, must be durable and tolerable within the body. The joints must be able to handle it, and the bones must be able to work as a system. and these are two different, that's a Gore-Tex kind of strip that's been used, but it wasn't good enough. And in conclusion, the perfect graft has yet to be found, but autografts are currently the most popular, but obviously they have their disadvantages. And the main goal of these studies is to reduce pain, reduce the recovery period, and the rate of re-tear. And creating a suitable graft synthetically is extremely difficult because you have to look at stiffness and compliance. It has to match the compliance of a normal ACL, and that's really difficult to do. So what does this mean moving forward? Using the information I collected from my original work, further research, and assistance from my future mentor, my goal is to design a suitable ACL graft that will meet the specific requirements of a functional reconstructed ligament. And my goal is to create the perfect graft, and I want it to match or exceed the strength of an original ACL. And this is a very difficult proposition, but I'm very passionate about this research, and I'm excited to see where it takes me. So, thank you very much.